Hello everyone, this is Dr. Hall. Welcome to lecture 16. In lecture 15, we learned about how the somatic motor system works, everything from starting with the motor cortex and ending down at the neuromuscular junction. So what we're going to do in lecture 16 is talk about disorders, neuromuscular disorders, because it gives us a really unique opportunity to review the normal physiology and see what happens when it doesn't work correctly. So I've broken it down kind of talking about the different ways in which we broke down how it works normally, so kind of going almost anatomically. So we're going to start with cerebral disorders, talking about stroke and cerebral palsy. We're going to talk about disorders of the modulators of the motor system, of the cerebellum and the basal ganglia. And then we're going to talk about disorders that involve the pathways. This was kind of the best way I could categorize this group. And then ultimately talk about disorders affecting the neuromuscular junction. So we'll get started with things that are disorders to the cerebral motor cortex. So here's a great opportunity to review. So that prefrontal cortex in the front of your brain is your decision-making, planning, executive function part of your brain, the part that makes me decide to go up and get a cup of coffee, as I talked about in the last lecture. Then I'm going to use my posterior parietal cortex to figure out where everything is and what pathways I need to negotiate, where I'm going to find the items I need to pick up or whatever it might be. And then I have these motor association areas. So both the premotor area and the supplementary motor cortex are these motor association areas. And they're the ones that kind of look at all the things that need to happen and figure out what's the sequence of muscle contractions that is going to result in the movements that we want to produce. And then they communicate that motor plan to the primary motor cortex, which is located right here in the precentral gyrus, right in front of the central sulcus. And that is where we find those upper motor neurons that are going to send the action potentials down out to the body. They're going to synapse with a lower motor neuron, and then that's going to go signal the muscle to contract. So one of the important things to know clinically is that if there's a disease or disorder that is affecting the upper motor neuron, we tend to get what's called an upper motor neuron syndrome. So we all have resting muscle tone at baseline. Even when we're at rest, all of our muscles are slightly contracting. So we have tone, right? So if you take somebody's arm and you kind of move it like this, it doesn't feel totally floppy like a rag doll. They have to kind of intentionally relax it to feel like a rag doll. So we all have resting tone. So we're going to talk about if you have an upper motor neuron disease, it's going to cause an increase in that resting tone. And the reason for that is that the brain's overall baseline tonic output is inhibitory. So remember, we learned that in the basal ganglia. So when the brain is intact and functioning normally, those upper motor neurons are kind of sending inhibitory signals. So normally they're suppressing that tone. If you have a disease of the upper motor neuron, you have increased tone. So things are stiffer than they would otherwise be. Now, if it's a severe problem with the upper motor neuron, you're going to have full paralysis. If it's not as severe, then you're going to have paresis or weakness, so kind of partial paralysis. So what we see is if there's an upper motor neuron disease, you have increased tone, often referred to as spasticity. Everything is just kind of tight and contracted all the time. You're also going to see significantly increased reflexes because normally the brain, the upper motor neurons have an inhibitory effect on the reflexes. People who have conditions that affect the upper motor neurons are going to have really brisk reflexes, or sometimes, like say this is my leg and you do a patellar reflex, sometimes it'll go boop, 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 just from one hit, right? So you're going to have increased reflex or hyperreflexia. All right, so that's upper motor neuron diseases. So obviously, if it's affecting the cerebrum, it's going to be an upper motor neuron disease. So the first one we're going to talk about is cerebral palsy or cerebral palsy. What is this? So palsy means some type of weakness or paralysis. Cerebral, it's of the cerebrum. So this is caused by brain damage that happens to affect the motor cortex. It's something that is present at or soon after birth. So it's something you're often born with or that it develops very early on in your life. And it's due to some sort of brain damage. Most commonly, something caused low oxygen to the delivery to the brain, either as it was developing during pregnancy, during the childbirth process itself, which can be very stressful physiologically for both mom and baby, or sometimes even after birth. There are some things that can occur that can cause brain damage. So the thing about cerebral palsy is it's something that happens. Boom, you get brain damage from something that happened, but then it's not progressive, which means it doesn't get worse over time, right? You had this damage, that's it. You're no longer being exposed to whatever toxin or stressor or mechanical problem it was that caused it. So it's not going to get worse over time specifically. Now, this is an upper motor neuron disease, so we're going to see spasticity, we're going to see increased tone, we're going to see increased reflexes. I wanted to take a moment to talk about one potential cause of cerebral palsy because it's something that a lot of pediatricians are becoming worried about. So, what we're looking at in these two images here are the MRIs of two different infants. So this one here, I want to draw your attention to a couple of things. One is if I make a line down the middle of this skull, we will see that those lateral ventricles are shifted over. This is called a midline shift. This is not a good sign on an MRI. It means that something is pushing things over. I guess this way, right? So it's mirror. So what is pushing and squeezing the brain over to that side? Well, it happens to be this right here. And this, I don't expect you to know what this is. I don't expect you to be able to read MRIs. So this is blood. And this is blood in the subdural space. So this is actually a subdural hemorrhage. And so that is squishing the brain so it can cause brain damage. In the other view, in C here, this is a different infant. Again, we are seeing that midline shift. So these are the lateral ventricles here. They're pushed way over. And they're really constricted, they're really small. So there's something that's really taking up a lot of space. And this is kind of obvious, but this is bleeding within the brain. So as opposed to this is bleeding around the brain in the subdural space, this is bleeding within the brain tissue itself. So why would an infant have bleeding in their brain? Well, there's lots of different things that can cause that. One is shaking a baby, but another one is cerebral hemorrhage bleeding that occurs due to vitamin K deficiency. So the interesting thing about vitamin K is it's something that we need in order to clot our blood normally. So without enough vitamin K, your blood can't clot normally, and what would normally be a little bit of bleeding can become a lot of bleeding. So most babies are born deficient in vitamin K because it's actually produced by the gut microbes in our intestines. And when we're first born, we don't have any microbes in our intestines. So they're usually deficient in vitamin K. So their head during childbirth, as they were getting squeezed through the birth canal, is subject to a lot of mechanical forces. And so sometimes there can be a little bit of bleeding as a result of all that squishing, especially if it was a very difficult birth. But normally it's not a problem. But if you don't have enough vitamin K, it can cause catastrophic bleeding. So for that reason, all newborns are typically given a shot of vitamin K. So it says IM vitamin K, that means intramuscular. That's a shot, they put it right into their thigh after birth. This started as a routine medical practice in the 1960s because it was discovered then that the cause of those newborn brain hemorrhages was vitamin K deficiency. And they figured it all out. And then they figured out that if you give vitamin K, it will prevent that from happening. So this was a huge success story because these rates of massive, devastating, often fatal bleeding or leaving a child irreparably brain damaged dropped from 1,700 per 100,000, which is 1 in 59, to 1 in 100,000. So we almost never see this type of vitamin K-induced hemorrhage anymore. Except that a lot of folks in recent years have started declining or refusing the vitamin K shot. So you may be well aware that there are a lot of folks who are currently mistrustful of the medical system and of any type of intervention, from vaccines to all kinds of things. And so people have started refusing the vitamin K shot. Now, in 58 out of 59 infants, they're going to be just fine, right? And then people get that reinforcement. See, my baby was fine. You don't actually need it. Right? So pediatricians are sounding the alarm now because we're starting to see an increase in rates of cerebral hemorrhage in infants because people are refusing the vitamin K shot. So, highly recommend, right? This is an incredibly successful and very, very safe intervention. We have lots of data to show that it's safe. If you're curious about it, ask me. I'll point you in that direction. So back to cerebral palsy. So it's an upper motor neuron condition. So we're going to have palsy or paralysis, which could be partial or complete, of some muscles, depending on which parts of the primary motor cortex are involved. And then we're going to have the increased tone and reflexes because it's an upper motor neuron condition, and these kind of stiff jerking type movements for those muscles that are still able to move. So this is an animation of a kid who has cerebral palsy and can walk, but you'll notice a couple of things. So notice how they're walking up on their toes, and that is because the calf muscles are constantly contracted, right? So they're unable to relax those muscles. They have that spasticity, that increased tone. Notice too that their knees are always bent, their hips are also always flexed, right? So these muscles are kind of chronically activated. We have this increased tone or spasticity. The second condition that we're going to talk about is stroke. So a stroke is damage to neurons of the brain, usually due to lack of blood flow from one of two main reasons. Most of them are what we call ischemic. There's been some type of a blockage in the blood vessel. So here they're showing you a blood clot that has blocked the lumen, the opening of the tube of this blood vessel, this artery. Now, most of the time, it's not just a clot. Most of the time, there's also a lot of like atherosclerosis that has caused a lot of narrowing of the blood vessel already. And then all it takes is a little tiny clot to cut off the blood supply. The other type of stroke that can occur, as you see here, is a hemorrhagic stroke where a blood vessel bursts. These are less common, but if blood comes out into the brain tissue, that's not good. It needs to stay in blood vessels. It's very toxic to the cells if it's not in blood vessels. And then, of course, if blood is leaking out this way, it's not going where it's supposed to. So if the stroke affects a part of the brain that's involved as part of the motor cortex, then it can cause motor symptoms, and that would be another upper motor neuron syndrome. So things that you can see vary a lot depending on what part of the brain is being involved. Now, it's usually going to be contralateral, right? So the right side of the brain controls the left side of your body and vice versa. So this is one of those little mnemonics: be fast to recognize the signs of stroke and get help immediately. So they might have loss of balance or coordination. They might have changes in their vision, especially if they're losing control of their extraocular muscles due to involvement of those areas of the motor cortex, because you're seeing double. They could have drooping features on one side of the face due to muscle weakness there, or weakness in an arm or a leg, again, due to involvement of the motor cortex, or difficulty speaking or difficulty understanding others, right? So these are all different signs of brain dysfunction. And then the T always stands for time. So we want to get folks who are potentially having a stroke into treatment as soon as possible, because we can actually often help restore normal blood flow to that area of the brain and stop the ongoing damage. So this is a nice reminder that different arteries supply different regions of the brain. So the anterior cerebral artery is, look, supplying part of the prefrontal cortex, also some of the premotor areas and some of the primary motor area, and look, also primary somatosensory area, all supplied by the anterior cerebral artery. So if you get a blockage in a branch of that artery, it could affect all of these different brain regions. Then look at the territory of the middle cerebral artery. Huge, right? So we've got temporal lobe, parietal lobe, frontal lobe. We have all of these motor cortex areas right here. We have a lot of somatosensory areas here. Auditory processing right here. So that's a big one. And then our posterior cerebral artery, again, also temporal lobe and occipital, right? So you might have some visual symptoms here. And look, here's that posterior parietal cortex, which is part of that dorsal stream for remembering where things are. So you might have difficulty kind of understanding how things are oriented in space. So after a stroke, you're going to have, if it affected motor areas, you're going to have upper motor neuron syndrome. So a couple of examples of what we see. This is someone who had a stroke that affected their left upper extremity, so it would have been in their right frontal lobe, and they're showing you that at baseline, the muscles are contracted, so they have this spasticity, right? And they're having to use their other hand to open up those fingers because those muscles are kind of tonically contracted. And then this is a gentleman who is walking after a stroke, so he's using a cane to help himself. Now, his left side is normal. His right side is the side that is impacted by the stroke, which means the stroke was on the left side of his brain. And you see how that right arm is held stiffly, and you also see how that right leg is stiff. He can't bend the knee, he can't bend the ankle. It's kind of like a plank of wood there. So again, showing you that upper motor neuron syndrome of spasticity, increased tone after an upper motor neuron injury. So what do we do for stroke? Well, acutely we have, so in the moment, right, as it's happening, we have clot busters and other treatments to remove blockages. Sometimes they'll go in and suck it out, or they'll use a stent. So there are lots of interventions potentially available. So neurologists will tell you time is brain. Call 911, get them into medical care as soon as possible, because that first hour is a time when, if you intervene early, you can often prevent permanent damage from occurring or limit the permanent damage. Now, after the acute event is over, it's going to be really important to work to regain function and also adapt to your new reality. So physical therapy and occupational therapy are going to be really important components of that. And then you're also going to be doing things to decrease your risk of having a future stroke. If you've already had one, then there's something going on that puts you at increased risk. So we want to decrease your risk of having another stroke as much as possible. So that would be things like treating high cholesterol and high blood pressure and diabetes, stop smoking, stop drinking, eat healthfully, exercise regularly, all of those things that we know help prevent stroke and heart attack. So in summary, our cerebral disorders of movement are going to result in an upper motor neuron syndrome, which is going to have increased tone, or what we call a spastic paralysis. We're also going to have hyperreflexia. Cerebral palsy is due to brain damage in the infant that occurs for a variety of reasons that happens to affect the motor cortex. So I took that opportunity to talk to you about why vitamin K is given as a prophylactic to newborns to prevent cerebral hemorrhage. Before we started doing this, the risk was about 1 in 60. Now it's 1 in 100,000, so a massively successful medical intervention. Cerebral palsy is non-progressive. The damage is already done. It doesn't get worse over time. And they may also have other symptoms if the brain damage affected other brain areas. They may not. It might just be the motor area, but they may have other symptoms as well. And then stroke is when you have death or damage to brain cells due to lack of normal blood flow. Most of the time it's ischemic, a blockage in an artery. And then the symptoms are going to depend on what part of the brain that artery was supplying, as we talked about. And of course, they're going to be contralateral because all those axons cross. If somebody is potentially having symptoms of a stroke, time is brain. Call 911, get them into the medical system as soon as possible because early treatment can make a big difference in outcome. And then long-term preventative measures are going to be really important. All right, that was a long one. So thanks for sticking with me. Those are neuromuscular disorders where the problem is in the cerebrum. Next, we'll do the modulators. See you there.